Elevated Lp(a) is killing a lot of people, and unfortunately, it's still going undetected. And I think it's unacceptable. So, first, a big thank you to my patient Ron for letting me share his case with you. What we're going to do is I want to teach you what Lp(a) is, why it matters, and just what we can do about it. And before we get into the video, I just want to say this information really can save lives. And so as you're going through this video, if you find it helpful to you at all, please just share it with someone you love. Just a little information can go a long way to saving lives. So Ron came into my clinic a few months ago and he wanted a second opinion. He had a fainting episode at a concert. And, after he had this episode, he saw his primary care doctor, he saw a cardiologist and a neurologist, all did kind of a standard workup. And the end result was, everything is fine. You look great. And I mean, the honest truth is when Ron came in to see me, your first impression is, this is a fit man. He's 53. He's got a healthy body weight. And as you look at the first level of his case, right, his blood pressure was fine. He's a non-diabetic. He doesn't smoke. His cholesterol was fine by standard markers. His LDL was 99. And as I like to do in my practice, we really dive into the lifestyle. And he's health conscious. He cares about what he eats. He's trying to minimize processed foods. He sleeps 7 to 8 hours a night, and he feels rested when he wakes up. He's got an intense but stressful job that he likes, and he tries to exercise regularly. And the only real knock was that he would drink red wine 4 to 6 days of the week. But there are studies that show perhaps some amount of red wine can be helpful for a longevity benefit. So when you look at this all in all, it would be very, very easy for a doctor to say, get out of here. You're fine, right? And that's the trick. And that's why really focusing on Lp(a) is so important, because it can be missed so easily. So I look at Ron and I say, okay, we just want to be sure. I don't think things were done as thoroughly as they could be, right? So he had a stress test as part of the workup from his cardiologist. And, this is a guy who can exercise intensely. He can get on the treadmill and get his heart rate up. He doesn't have chest pain, right? So the chance that he has advanced atherosclerosis and blockages, the chance you're going to find that on stress test is going to be pretty low, right? Previous physicians, they just didn't order an Lp(a). And at the end of the video, you are going to know why you should be ordering Lp(a) on your patients. And the fact of the matter is that it's easy to overlook. And then importantly, when I'm screening someone who appears fairly healthy for cardiovascular risk, I think a coronary calcium score, this is a CT scan, very focused on the heart, is just absolutely critical. Because what that can do is that can detect atherosclerosis years before you become symptomatic, years before you see anything on a stress test. And the way this works is as you develop atherosclerosis, right, you get calcification in the blood vessel, and the CT scan can see that calcification. And we know from lots of work and imaging studies that the higher the calcification levels, the more likely you have blockages in your heart. And so this can go on for years without any active disease. The first heart attack, I think the mortality is 50%. So what you don't want is something like this to be going undetected for years and then surprise you out of the blue. So we got a coronary calcium score on Ron, and it's scary, right? It was 510, right? Really, really bad news. And calcium scores are pretty neat because they'll actually show you where the density of the plaque burden is. And so you can see here the LAD, the widowmaker, right, as it's called, because this is the location for most heart attacks that are fatal. It already has a plaque burden, right? You can see the plaque burden here. It's primarily a total score of 510, primarily in the LAD. Now, it's not isolated to the LAD in cases like this. You see it all throughout RCA as well. And so despite a healthy lifestyle, a fit man, unremarkable labs, and a stress test, he's at very high risk for a heart attack. And I'll show you why. But first, just to get an idea of what this means, a score of 510. So for his age group, you have the 25th percentile, the 50th, the 75th, the 90th, and the 90th percentile. So poor Ron is above that 95th percentile, really, really quite high for his age. And we really don't want that one. This is the test I tell people, it's the only test that you want to get a 0 in, right? You want no calcification. But, Ron has already developed a disease burden. And think about this. Think of if we had not gotten the coronary calcium score, got a standard lipid panel, right? It looked great, right? Oh, his HDL 49, total cholesterol 162, LDL 99. This is good stuff, right? You have to order the Lp(a). It will go missed. I'm going to teach you exactly what it is, but it's cases like this why it's so scary, right? You have to go out of your way and get this lab just to see, are we missing the 10 to 20% of the population that have this genetic inherited problem? So what is it? Okay, here's art class with Dr. Mather. So a picture is worth 1,000 words, and maybe these pictures will be worth 500. I don't know. But here are the basics. So you've got your blood vessels, and LDL are particles that flow in the bloodstream, and they are not cholesterol. So people will call this bad cholesterol. That is dumb. That's not right. Lipoproteins are carrier molecules. So inside this little bubble, you've got cholesterol and triglycerides. And, if this was an HDL, it would just be slightly bigger, and you have VLDLs, and you have all sorts of different size particles. Now, the way that you might have seen, will just be an aside, is on every LDL particle, you have something called an ApoB, right? And that is a little side molecule that we can directly measure to get a very accurate read of what the LDL is. Because in these studies, this is calculated, and this can be subject to bias, particularly in patients who have insulin resistance. So in a lot of times you can say, okay, the LDL is probably going to be right on the money for the standard lab, but not always, right? So we want to be careful. And a lot of times I'll have my patients get an ApoB just to check that that calculation is correct the first time. And then if they're in alignment, we don't need to keep getting it. So what's Lp(a)? So Lp(a) is like the evil cousin, right? The evil twin of LDL. So it's the same LDL molecule. It's the same, carries triglycerides and cholesterol inside. It has an ApoB, but it has a tail. It has this extra molecule. It's called Apo a. I think we're down to 200 words. Apolipoprotein a is this guy right here. And what this means is that this can carry oxidative phospholipids that can do more damage to the endothelium. So the whole point of why we care about LDL is that the higher the concentration of LDL, right, the more collisions we're going to have with the inside of the blood vessel, the endothelium. The more collisions you have, the more atherosclerosis you develop, right? The more intrusion of particles you get in there, the more foam cells and inflammation you get. And over time, more blockages, right? You start getting the plaques on the inside of the vessel. So lower is always better because you have less collisions, and over time you have less probability of developing heart disease. Now, Lp(a), the way I think about it is this Lp(a), same size, it's worth 2 or 3 collisions, right? It does that much more damage, probably a lot to do with this apolipoprotein a molecule that has the oxidative phospholipids on it. When it actually gets into the lining of the blood vessel, it causes a lot more inflammation. So that is kind of the biochemistry of why we care about this. And hat tip, about 8 or 9 years ago, I learned about this from Peter Attia's podcast, and there's a 3-part lecture series with Thomas Dayspring, Dr. Thomas Dayspring, who I think is just one of the most brilliant lipidologists that we have. And if you want to learn more about that, please just go check out that 3-part podcast. They're like 2 hours each, right? But for like 6 hours, I think I've gone through them 3 times. I honestly feel like you're almost at a lipid fellowship if you can get through those. So those are pretty wonderful resources. So we think that about 10 to 20% of the population has elevated levels of Lp(a). And I'll show you that the higher the Lp(a), the more risk, which makes sense. But I just like this picture. These are the Danes. So these are not the Americans, but this just gives us an idea. Most people have low Lp(a) levels. But 20% of the population are going to be in a place where they're elevated and they're causing elevated disease risk. Using these cutouts, we really see a marked increase in risk over that 125 nanomole meters. And so, the risk may be something like this, right? The higher it gets, with a bigger spike at that 125 mark. This is a range from the European Atherosclerotic Society. There's no agreement on this yet. We all the different governing bodies of cardiology and lipidology, everybody has a different take, but these are the numbers I find most practical and that I tend to use in my practice. So that's, for that reason, is why it's there. All right, so to understand why this is a problem, we're going to go through some of the science. And I'm not going to beat you over the head about this, but to know why this matters, you just have to know these studies, right? So this was done at Mass General Brigham, and this was a retrospective review of over 6,000 patients, and they were adults over age 18. Average age was 54, right? So Ron is 53, so he's right in the middle here. Mostly men, and they didn't have heart disease. And what they wanted to know is, what is the relationship between Lp(a) levels and their first heart attack, right? What did it look like? And they defined Lp(a) levels in this study as the highest was 168, and then the lowest 50% was below 19. So those were kind of the definitions. And here's a citation if you want to dive a little deeper. And so they're measuring Lp(a), and they're measuring these gentlemen, these patients, not saying gentlemen, they're measuring all the patients, for an average of about 9 years. And when they had a first heart attack, right, then they're marking that. And they're also tracking, are they diabetic? Do they have high LDL, right, or low HDL? Do they have high blood pressure, smoking? These are the traditional modifiable risk factors. And it's actually kind of hilarious in the study, these internal medicine doctors, all these stupid acronyms, they call them SMRFs, right? Standard modifiable risk factors. It's just the stupidest thing. So why don't we just call it risk factors? We have to have a stupid name. But anyways, it wouldn't be a study without a stupid name. So looking at this population, they had risk factors, right? So 23% didn't have any of these, 30% had one, and all the way down. So what we would expect, and you'll see in the next slide, is the more standard risk factors, the more people smoked, had high blood pressure, high cholesterol, and diabetes, the more risk of heart disease that we were going to see, higher the risk of having that first heart attack. So what did they find? So let's start by looking at that low Lp(a). That's the numbers in the blue. And what this is referring to is that the patients with none of those risk factors had a very low incidence of having their first heart attack. And then as they added more risk factors, their levels went up, right? That's perfectly expected. That makes sense given all the information and epidemiology that we have in heart disease. The more risk factors, the more likely you are to have a heart attack. But let's take a look at the Lp(a), right? You can just see the red bar. That's takeaway number one, right? Highest group of Lp(a) dwarfs, right, the number of heart attacks that we're seeing in each of the risk groups. But then check this out, right? Look at the risk of someone who's perfectly healthy. That you could call this be Ron, right? Ron is non-smoking, non-diabetic, athletic guy, eating a good diet. Look at the rate here of the Lp(a), of the low Lp(a) group. So this is the group that we'll say smoking and diabetic, right? Their risk is the same as someone with elevated Lp(a) living the most clean, healthy life you can imagine. And this is why it's so dangerous and why it's so important that if you're a doctor, that you get this drawn on every single patient that you're worried about cardiovascular disease, and even those you aren't. So in my practice, if someone is age 50, they get this marker. If they're coming in and I'm ordering blood work on it, I just want to know, do they have it? And it's inherited, right? This is largely genetic. And so oftentimes you can get it once. You can say, you don't have it. Great, right? Or you can say, oh my gosh, you do have it. This really changes the calculus of what I want to do with you when I'm trying to get you to live longer, when I'm trying to get you not to have a heart attack. And so we're seeing this is just pretty outrageous that you can see this degree of risk for people with a high Lp(a). I mean, just look at these numbers. It's crazy. It's such a large independent risk factor. It blows my mind that more doctors are not getting this. So again, having high levels of Lp(a) will give you heart disease independent of how healthy you live. You can eat the most pristine low-carb diet and you can do all the cardiovascular training you want. You're still going to have the risk factor of a diabetic hypertensive. That's how scary it can be. And every year or two, you'll see, an article in the paper of the marathon runner eating carrots and broccoli, drops dead of a heart attack. Everyone's confused. This is why. This is why patients are dying early. This is why you'll have groups of families who have really high heart disease risk. You'll see this in your clinical practices, but you're like, oh, the LDL's fine and their blood pressure is good and they're all thin. This can really go under the radar. So what we know is when we're looking at the hazard ratio, right, of those with the highest to the lowest Lp(a) levels, they have a threefold increased risk, right? A hazard ratio of 2.9. That's a really large number. And so really, really important that we're paying attention to this. So what do we do about it? Most important piece, right? And in my practice, you don't get anywhere until the fundamentals have been done. So for Ron, we said, all right, look, you've done a lot of good things, and maybe the fact that you haven't had a heart attack probably had a lot to do with how healthy you've lived, but you are now at such a high risk that we have to really buckle down. So what are we going to do? I said, all right, we're going to lower your body fat. And we're going to increase your muscle density. And so how do we slowly tweak in a sustainable way to bring your body fat down and your muscle higher, right? In my practice, blood sugar is important. Now, this was not an issue for Ron, but if this was anyone else, if we are having spikes of blood sugar after meals, that absolutely has to come down, right? What can we do to increase the movement, right, in patients? How can we get them exercising more? We know exercise reduces heart attacks. Right? This is not brain surgery. This is easy stuff. There's 1 billion studies showing that intense exercise lowers cardiovascular risk. Let's do it, right? Are we sleeping enough, right? Do not pass go if you're not sleeping 8 hours. Are you exposed to other toxins, right? These are basics that can be done in any patient. Screen for heavy metals. I will link to another video I made on how I approach this in my practice. It's also an independent risk factor that's missed, but let's not expose ourselves to unnecessary toxins. And then in my practice, given how strong of a risk factor we know this to be to having heart attacks, I have a target, somewhat arbitrary, admittedly. I want their LDL to the 5th percentile. So that means generally the LDL is less than 70 and the ApoB is less than 60. And to get levels that low, you almost always need to use a combination therapy of a statin and 𝐻𝐸, right? Alternative options are the PCSK9 inhibitors. So these drugs have been shown to reduce Lp(a). And so that is absolutely, I think, on the table for these patients. And there'd be some patients who I think would be very interested and a good candidate for those, and then some who are not. There are many who you can get, I think, to goal and reduce the risk as well as can be expected just with the statin, right? And then in some patients, really only when there is a dogmatic viewpoint against statins, I just see this kind of ridiculous amount of misinformation about statins in my practice for the patients that come to see me. I will compromise because I know that using a combination of red yeast rice, CoQ10, and high-dose fish oil, I can generally get a 20% reduction in LDL in my patients. And so for some patients, that might be appropriate. And there are patients who are extremely sensitive to statins, a very small number, but they're out there that they just don't tolerate any statin, no matter if you give them Crestor or Lipitor or Pravastatin, they just react. And so sometimes you just have to use what tools you have. But this is such a risk factor that I really, this is one of the few things I jump right to drugs. I really just want to nail this risk and not mess around. And just to preempt the YouTube comments on how evil statins are, So we have a 2025 hot off the press meta-analysis from one of the best journals out there. 6 placebo-controlled statin trials, 28,000 patients with Lp(a), and the name of the game here is the statins reduced the risks, right? So you see an absolute reduction in disease, right? So this is ASCVD, and that's where I think the rubber hits the road. Like for people who are, I think, hesitant for statins, not everybody needs a statin, but these patients do, right? So if they can tolerate it, they deserve it. We don't need to be putting it in the drinking water, but we also have to be honest about what the data says. And if you care about saving lives, you care about not dying of a heart attack, you should probably be taking a statin. It's also good, there's a group of very zealous low carb dieters, and they have all this ridiculous nonsense about, if you just get your insulin down, your LDL can be whatever it is. It can be 400, it can be 200. And it's really nuts to me to believe that you really have to go out of your way to avoid all of the relevant science. And, I hope this shows that a form of LDL, right, is equivalent to 2 standard cardiovascular risk factors. And we think somewhere between 10 and 20% have problematic levels. That's a lot of people walking around at risk. So what did Ron got? So Ron was fit, but we wanted to optimize that, right? So I wanted a body composition scan. I wanted repeat lipids, and I wanted him to bump up his daily movement, 10,000 steps a day. And so part of that was me fussing at him for getting a standing desk, right? I think these are awesome. You can sit, you can stand. I wanted him bumping up his resistance training. I wanted him adding some fasting. And I even fussed at him about potentially getting a underdesk treadmill for more steps, because these are very simple, easy ways that we can get more movement in. I mean, the truth is that most of us physicians, we're sitting at a computer all day, and we have to find ways to move our body. Our bodies were meant to move. They were designed to move. They were not designed to sit all day long. I started him on rosuvastatin and ezetimibe. And in his case, we did use some supplements listed here, but the real gain for me, particularly in his case, is going to be really optimizing his body composition with the movement and resistance training. So getting more muscle, less body fat. And then on top of that, really getting his LDL under control. Now, we have room to tweak this, right? We can go up or down on this dose. And if he doesn't do well on this, if he doesn't do well on rosuvastatin, then atorvastatin, and then pitavastatin would be my next go-tos. And so I think you have a lot of options if you start here. But most patients, this dual therapy is all you're going to need. It's kind of just start and stop there. It's pretty darn simple, right? So takeaway, doctors, get Lp(a). It's a single blood test. It's not expensive. It's a one-time screen, right? You are going to save lives. And this happens to me a few times a year. I don't have a practice that's dominated by lipids or cardiovascular management, but a few times a year, I will find a patient like this. And when you find them, you add years to their life. They will cry. They will be the most grateful patients you will ever meet. Ron, I can't remember if you cried or not. I might have, but if you're there, if you're watching, I don't remember. But this is why we go into medicine. We want to preserve longevity. We want to prevent people from having heart attacks before they need to. We want to keep them healthy and able to hang out with their grandkids, right? If you're a patient, ask your doctor to get Lp(a). It's not hard. Fuss at them, right? Doctors, I have a practice where I see patients 3 days a week. And so I have a lot of time to research and study and learn the things that I may not know that much about. A lot of doctors don't have the privilege of doing that, right? They are being paid by insurance and they have volume to meet from their hospitals that employ them, right? And they may not have the time. If you've watched this video, you probably know more than 90% of physicians out there about Lp(a). It's the honest truth. And so ask your doctor to order it. Most of them will be like, oh, I don't know what that is. Sure, I don't care. Get it. then you can fix it. Or you can say, hey, it's not a problem. We have a party. So that is it. I hope you found this helpful. I hope you can pass this along to anyone you love who you might be worried about their cardiovascular health. And I hope you're well. I hope life is good to you.